quite a bit.
Kia ora, welcome. I'm Adele Gauthier from Breast Cancer Foundation NZ. Tonight we're talking about breast cancer surgery and what you need to know if you or someone you love is about to go through it. What are the options for surgery and what might your surgeon recommend? And how do you prepare beforehand and recover afterwards? Well, let me introduce you to our panel who are going to cast some light on those questions. We have two patients who each had a different surgery, Amy McCauley and Barbara Sternfels, breast surgeon Dr. Mike Puttock, and breast care nurse Katrina Barrett. Thank you all so much for joining us. Before we get started, some housekeeping. This is our second webinar using Teams instead of Zoom, so it might look slightly different if you haven't seen one in a while. If you have technical problems, click on the chat icon and ask for some help, and our support team will jump in. You can use the chat during the webinar to ask questions, which we'll get to later, and you can also chat to other people who are watching. Don't worry about missing out on information while you're chatting. The webinar is being recorded and will be available on our website tomorrow. So let's get started. First, we're going to hear from Amy McCauley, who was diagnosed with breast cancer in 2022 at age 48. Amy, that's quite young. Tell us what happened, how you were diagnosed, and what surgery you had.
Sure. So I noticed a lump in my breast and I went to the doctors, and I was then referred to the breast clinic for a mammogram, an ultrasound and a biopsy. It was about a week later. When I was there, I was told that I was most likely had breast cancer, and a week later it was diagnosed and it was confirmed that it was indeed a tumour, and it was 8 centimetres. So I met with my surgeon to discuss my options, and then I began my 18 weeks of chemo prior to surgery, and also had Herceptin, and my diagnosis was HER2 positive. So my surgeon advised me of all my different options. So it was a decision for me between a lumpectomy or a single or a double mastectomy. I made the decision to have a double mastectomy, and that decision was between my husband and I. I talked to him about it. I sort of felt like my breast had really served a purpose. I'd breastfed all my children, and it felt like just that was okay to let them go now. So the night before I had my surgery, my kids threw me a bye-bye shitty titty party. And it was, bittersweet. And my parents had come over from Scotland as well, which was really lovely to support. So during the surgery, I had 11 lymph nodes removed as well. And so when I had the surgery, I was in this hostel for 2 nights, and then I returned home and had drains put in for a couple of weeks. So my focus really was just to bed rest. And, I was very fortunate that my family were there to really help and support me. I did want to keep moving my body. I was told how important it was to keep moving. So that year, actually, I committed to a daily swim in the sea. So that I had, halfway got through that, or it was 3/4 of the way got through that. So each day I did walk down to the sea and at least put my feet in the sea. So that was, something. I had my little drains beside me, but it gave me a focus each day. 3 months after my surgery, I started radiation therapy. So I had 15 sessions over 3 weeks. So this was after my scars had healed up. And then, unfortunately, 3 months later, I did develop lymphedema in my right arm following when I had my lymph nodes removed. So with the lymphedema, I've used various sort of medical and holistic therapies, such as a compression sleeve and massage, to really help keep it under control. And I've been working on my fitness. It's been a huge part of my journey. So keeping fit throughout this has been a massive thing, not just for my physical health, but a huge part for my mental health as well. Ultimately, I guess I opted not to have the reconstruction. I kind of felt like I wanted to keep my breast have a symmetry. I didn't want to have one natural. I sort of used the word dog's ear, one tennis ball and one. So I was like, I just wanted to have its symmetry. I just wanted to be finished with my surgeries as well. I didn't want to have to keep going back. So that was just a really personal decision for me. But I guess everyone's decision is going to be very unique, but this is just what felt right for me. So beyond that, where I am today, I'm having follow-up appointments with my doctors and my annual checkups. My scars have healed really well. You know, it's just a case of getting used to having no breasts. What I have noticed is my energy and my fitness is a little bit lower than what it was, but I fully expect that. You know, having when I first was diagnosed having breast cancer, it sort of felt like this really fast-moving train. And I had to just jump on, and now I'm at the station taking a breath and it's kind of catching up on me. Obviously body image is a big consideration post-surgery, so it is a work in progress. I'm not going to lie and say it's all good. It is challenging at times. But I also believe that, you know, my sort of age as well, I'm just like life. I just want to be here for my kids, for my, I just want to be here. So that was for me, it was a no-brainer. So that was my story.
Wow, thank you so much, Amy. We really appreciate you sharing that experience with us.
It's a pleasure.
At home, don't forget to use the chat box if you want to submit questions and to chat to each other. Now, next up, we have Barbara Sternfels, who was diagnosed last year, age 68. Barbara, welcome. It's great to have you here.
Thank you.
Now, I know your choices were different from Amy's. Tell us how that came about and how it all went.
Okay, yeah, so I had a routine mammogram. I've been having annual mammograms for decades, all clear up until then. This was just after my 68th birthday, just over a year ago. A 1.8 millimetre lump was found under my left breast. A biopsy indicated it was stage 2, grade 2 invasive ductal carcinoma, which at this time I didn't have a clue what any of that meant. And ER and PR positive, and the test for HER2 was equivocal at that stage. I was sent for MRI imaging, which also revealed some precancerous cells on the right breast. I talked over my options with a surgeon, and I really had the choice of a partial mastectomy with follow-up radiation on the one breast, or full mastectomy on that breast without radiation. No one actually talked to me about having a double mastectomy.
Right, interesting.
Yeah. I don't even think I asked about whether that was an option. I can't remember.
Yeah, one of the things we should just say for you folks at home, and I think it was on the earlier slide, but just to say that we do use several different terms when we're talking about breast conserving surgery or lumpectomy or partial mastectomy or wide local excision. When you hear us saying any of those things, we're all talking about, we're talking about the same thing basically. So just if you're not familiar with those. Sorry, Barbara.
Yeah. Now, at that stage, it was expected that the lymph nodes would be free of cancer. So we weren't expecting that I would need chemotherapy. My initial reaction, like gut reactions straight off, was to opt for full mastectomy to be rid of the cancer and avoid radiation. I wasn't scared of surgery. I've had 3 orthopedic surgeries in recent years, so I know what surgery is all about. But I did feel scared of cancer and scared of radiation. So I spent several days getting more information and weighing up the options. I contacted the Breast Cancer Foundation and found the nurse Louise really, really helpful to talk to. And I talked with friends who had breast cancer treatment. Both of the options that I was had been put to me. One thing I did know for certain, and this didn't waver, was that I didn't want any reconstruction or implants. So it came down to a choice of either breast conserving surgery or going flat on the left side. And in the end, I decided on the partial mastectomy. And a factor there that swayed me was that you can always remove more, but you can't sort of add it back, especially as I decided I didn't want any adding back of anything. Yeah. So I had the surgery to remove the lump and 6 lymph nodes on that breast, and also to remove precancerous cells on the right, and stayed in hospital overnight for that. So post-surgery, I removed the bandages on day 4, and I visited the clinic 2 or 3 times over the next couple of weeks for the wounds to be checked and the dressings changed. Regarding pain, I found that all I needed was paracetamol and celecoxib, and Started off on, the maximum doses of those and got it down to like 1 a day. And at most I was on pain relief for about a week. The lymph node sites were more painful than the lumpectomy site. I was lucky not to have any real arm movement problems, but I was diligent with doing the exercises prescribed, and that may have made a difference. Hope so. Meanwhile, there was quite a long wait for all the lab results to come back, which was quite stressful. That delay was, I don't understand why it was a delay. Maybe the system was quite clogged up. I tried to occupy myself with going for walks. First went for a walk 2 days after surgery, which was a bit soon. Got a bit wonky. Yeah, the coffee at the end of it was welcome though. Yeah. By about a week, I was walking most days and trying to go a little bit further each time. I started riding my bike again once the wounds were sufficiently healed. That would have been after about 3 or 4 weeks. Unfortunately, the lab results on the lymph nodes showed that there was cancer in 2 of the nodes, and the diagnosis was changed then from stage 2, stage 3, grade 3, and the HER2 analysis also came back positive. So I had what's called triple positive cancer. So this escalated the treatment plan to include chemotherapy. And I started that about 5 weeks after the surgery. So it's 6 rounds of chemo every 3 weeks. And that chemo would have been the most grueling part of the treatment process. Yeah. So that's 6 months, I think, since the heavy duty chemo finished, and this is, haven't had a haircut yet. So this is my new hairdo for today. Yeah. Then following that, when I was recovered enough from chemo, I had 15 sessions of radiation over 3 weeks. And I've also had a further 13 rounds of Herzuma because of the HER2 positive. And I've just finished those. So that was it. Yeah. I'm now also on daily letrozole tablets to reduce the risk of recurrence as the cancer's hormone positive, which also involves 6-monthly infusions of zoledronic acid to counteract the bone density loss from letrozole. And for the next several years, I'll be having annual checkups and imaging with my surgeon, radiologist, and my medical oncologist. So it's been quite a year. In hindsight, I think the actual surgery was possibly the easiest part of the treatment. You recover from surgery wounds and move on. And as I said, I was used to surgery, so that wasn't unfamiliar. Yeah. The side effects of the other treatments have been more challenging, and I'm now sort of uncertain about what the new normal will be. I'm still getting used to, I'm still fatigued, I think possibly from, the chemo and radiation still, but the daily letrozole has a side effect of fatigue and also bone aches. So that's a kind little gift that I'm given. Yeah. I'm gradually getting more active like you. Yeah. I don't often sleep in the afternoons now. That used to be a daily thing. And I'm a lot more active now than I was in March when I finished radiation, and able to get back on my bike most days. I'm aiming to get back to 100k a week, gradually getting there. Yeah. Yeah, so that's me. I think I've coped pretty well. It's helped that I'm at this stage of life where I'm retired, got plenty of family support and no other responsibilities. So that's, I think, made the rigours of the treatment less severe. Yeah. Yeah.
Great. Oh, thank you, Barbara. There's a lot going on in your life over that last year or so. So thank you for sharing that with us. Now, we've had 2 different stories, and I'm sure there are many more variations out there among our audience too. Our next guest can help us understand why things are different for different people Dr. Mike Paddock is an oncoplastic breast surgeon at Auckland City Hospital and also a private practice. Mike, we really appreciate having you with us tonight.
Thank you for having me, Bill. Thank you, Amy and Barbara, for sharing. So what I'm going to do is I'm going to just give a bit of an overview of breast cancer and then talk about some of the ways in which we can individualise and personalise that for different women. Surgery is the mainstay of breast cancer treatment. And what you're trying to do with an operation in very simple terms is remove the abnormal bit of tissue and get back to normal tissue all the way around it. And actually that's the same for many cancers. Lots of people in New Zealand, for example, have skin cancers. And if you have a skin cancer, you try and remove the abnormal bit and get back to normal tissue. But there are some other subtleties around that. But in simple terms, what the surgeon's trying to do is a plan for the breast. We've touched on some of that already with people having mastectomies or having breast conservation, that's taking some of the tissue but not all of the breast, and a plan for the axilla, which are really talking about the lymph nodes in the armpit. So the breast surgery we can divide into being a mastectomy, with or without a reconstruction, and then there are other things around breast conservation, that's keeping your breast, and that's usually given with radiotherapy as well. And in some cases there's genuine choice, in some cases you'll have more recommendations made. In terms of taking lymph nodes out of the armpit, that's targeted because that is the first place that breast cancer is going to spread. It's going to move out of the breast into another part of the body. If we have low suspicions that there's any spread, we'll do a technique called a sentinel node biopsy. But sometimes people actually, when they get their diagnosis, find that they've actually got lymph nodes involved. And in those cases, we may recommend an axillary dissection, which is taking out an envelope of tissue containing most of the nodes in the armpit. One of the common types of mastectomy done is a simple mastectomy, and that's thinking about the breast as a breast tissue within a skin envelope. And it's removing all of that. And the most common type of mastectomy is a simple mastectomy. And that leaves the skin flat on the chest wall, and it allows people to wear more easily a prosthesis in a bra if they want to. And actually dressed, most people will look quite normal and you wouldn't know that they've had surgery. There are cases in which we'll do reconstructions at the time, in which case we can keep the skin envelope, and then we'd be looking at some sort of substitute breast tissue, and that can either be implant-based or sometimes moving some tissue around from the body. Reasons you might get recommended to have a mastectomy, in fact, many people may choose, it may just be a personal choice that that's what you choose to do, but if you're going to have it recommended, it might be because the tumour is quite large compared to the size of the breast. Perhaps there's multifocal disease, either there's deposits of cancer in different areas of the breast. Some people may choose that they don't want radiotherapy and avoid it by having a full mastectomy, and that may be due to personal preference, or actually in New Zealand due to geography by people living in rural areas. And usually, if people have got recurrent disease, it's more common that we'll recommend having a full mastectomy in that case if they've had breast conservation before. As Adele mentioned, there's lots of names for this, but breast conservation means removal of some cancer from your breast, but keeping most of your breast tissue. The other words used as a partial mastectomy, sometimes a lumpectomy, or a wide local excision. So wide excision is taking out the abnormal bit and getting back to normal tissue. And that's what we're really trying to do, but also with a good cosmetic outcome. Because actually what we don't want to do is leave women with a deformed breast that's actually very unsightly, uncomfortable, and actually struggle with clothing. One analogy I sometimes use, it's like we're trying to remove the yolk from a hard-boiled egg, but as we remove it, all we want to see is the white of the egg around it. We don't actually want to see the yolk, so that gives you that cuff or the safety margin around it. And usually we'll recommend that following breast conservation, that people have radiotherapy. Reasons we may not be able to do it is if we've got a very large tumour compared to the size of the breast, in which case we may say a mastectomy would be better. If there's multifocal cancer in different areas of the breast, and sometimes it's just not possible to give a good cosmetic outcome. And that may depend on where in the breast, which quarter of the breast, for example, the tumour is located in. And it's often easier to do it in the outer parts of the breast and less and harder to get good cosmesis in the inner parts of the breast and in the cleavage. We also say that we're trying to remove all the abnormal stuff and get back to normal tissue. And we really only know that's done once the pathologist has analysed it and we get the results back. and a proportion of women will need a second operation to clear that margin, and that can be up to 1 in 5 people. There are some other techniques that are available in some hospitals in New Zealand called oncoplastic techniques, and that's really borrowing some of the techniques of plastic surgery and bringing them into the cancer surgery realm. One of them, for example, would be what's called a therapeutic mammoplasty, which is using breast reduction techniques. A breast reduction at its core is removal of breast tissue and some of the skin envelope. And if you choose your reduction pattern so that the breast tissue contains your cancer, you can actually do a therapeutic operation for the cancer and have a reduction at the same time. Advantages are that maybe sometimes what someone has always wanted. So there's a silver lining to the diagnosis, but also it means that if you go on to have radiotherapy, you're actually giving radiotherapy to a smaller area of the body and be less likely to have any of the complications or difficulties afterwards. If there are defects in the breast afterwards, or there's not very good symmetry, another technique that some places can use is a thing called fat grafting, which is doing liposuction and injecting that tissue into the breast itself to remove any divots or defects that are there. That's usually done later, not at the time of the primary surgery. We are getting more and more New Zealand surgeons trained in oncoplastic surgery. It's not available everywhere, but it's much more widely available than it has been in the past. Up until about the 1980s, everybody was recommended to have a mastectomy. And in the 1980s, breast cancer wasn't talked about so much. There's much less awareness. People were less willing to come forward, and there weren't breast screening programs around the world. But as people became more aware of it, people said, and at that time, in the 1980s, everyone had a mastectomy. The first studies were done on keeping the breast in the 1980s. And that was finding that if you didn't do radiotherapy, there were quite high recurrence rates. But the long-term data from those studies showed that breast conservation or a wide excision or a lumpectomy or a partial mastectomy with radiotherapy had identical survival to a mastectomy. And even longer-term data and more modern data suggests there may even be a slight survival advantage to it. And that's certainly been held out in studies done, long-term follow-up studies of women across New Zealand. So if people are unsure what to do, and they say, what should I do? It tends to be that we may lean more towards breast conservation, but sometimes there is a genuine choice, and people may have a first initial reaction and then change their mind. So that does show the value of actually just being able to take the time, talk it through, ask some questions, come back, talk with the breast care nurses as well, and take your time to make a decision. One of the nice things for planning surgery is that actually breast conserving surgery and mastectomies take roughly the same time. So you can even book a surgical date and have a bit of time to change your mind should you wish in between times.
Right. That's good advice, Mike, because I'm sure some people don't realise that.
Yes, yeah.
Like
If you're doing a reconstruction, that's a much bigger deal. But if it's a simple mastectomy, breast conservation, very similar. So I'd say if you're talking with your surgeon, it's good to try and understand what their thinking is. They may be recommending something, saying, well, what's underpinning it? And if they say, well, why are you recommending mastectomy for me? Then it might be because there's multifocal disease, or they feel they can't get a good cosmetic result. And we'll talk a little bit about orders of treatment that follow as well. But sometimes a lot of it just comes down to personal choice, what's available, the stage of life one is at, and what your desires are. And I think what we're trying to do as surgeons is give women a good cancer outcome and have a good cosmetic outcome, and also have the chance to make decisions that they're not going to regret 20 years down the line and think, oh, I'm glad I didn't rush into something, that I took the time, I had the advice and got to make good decisions after that. So following surgery, we'll talk a little bit about it. There are other options to do, but I'd say that really surgery is getting rid of the cancer. Then the other treatments that we've touched on, which are some of the tablets like letrozole, the drug treatments such as chemotherapy and Herceptin and the radiotherapy, their aim is really to stop things coming back. So let's get rid of it and do some things to stop it coming back. Up until about 2001, 2002, most women would have an axillary node dissection. And the reason is to see if there are cancer cells or cancer deposit in the lymph nodes in the axilla. And certainly that's recommended now for most people who we can prove that they've got cancer in their lymph nodes at presentation. That's at the time of diagnosis. About 75% of women, though, don't have lymph node involvement when they're diagnosed, and it's more appropriate for them to do a thing called a sentinel lymph node biopsy, where you just take out 1 or 2 targeted lymph nodes and analyse those, which is the most sensitive way to pick up to see if there's any spread. I'm often asked, how many are you going to take? And there's a huge variation, anything from about 4 to 40, depending on different people, but it's usually targeting on an anatomical area, which is, in simple terms, the armpit. Amy talks a bit about having chemotherapy before the surgery. And I think another question you can ask is not only about what surgery would to have, but actually what additional treatments might be recommended. At the point where someone's getting their diagnosis, we sometimes have a lot of information, sometimes there's more information to come. Sometimes you can predict with more certainty what other treatments may be recommended. Sometimes you need the results of surgery back before you can make firmer recommendations. But I said at the beginning that there are cases where you can individualize what we're doing. And one of those is around chemotherapy. And there are some subtypes of cancer, and that's particularly ones that express HER2, or the other ones that are known as triple negative breast cancers, which don't express the estrogen receptor, don't express the progesterone receptor or HER2. And there are some benefits to people of having chemotherapy first. And those are really around being able to see how the tumour responds to treatment. A percentage of people, anything up to about 50% of people, the tumour during chemotherapy will actually melt away and virtually be gone at the time of surgery. And that confers a very good prognosis. If the tumour hasn't completely gone at the time of surgery, you then have the option of giving people a more extended drug treatment or more extended chemotherapy, or changing the chemotherapy agent to something that's more sensitive. There are also some other cases as well where at point of diagnosis, you're looking at somebody who's got quite a large lump in their breast, nodes involved. But if you can give the chemotherapy first, you can look at the way it responds. Some breast lumps will actually shrink, and people can change from needing a mastectomy into being able to keep their breast. And if there's a very good response in the axilla, you may not need to do a full axillary dissection. I talked a bit about sentinel lymph node biopsies as well, which is a smaller alternative to the axillary dissections. And that's really taking out 1 or 2 lymph nodes from the armpit. Every area of the body drains lymphatic fluid to some nodes. If you've ever had a sore throat, you'll know that your throat ones go to your neck. But as well as being part of your immune system for infection, the lymph nodes are part of your immune system fighting cancer. And I think of them a bit like a filter or a sieve that stop cancer cells getting around your body. What we do is put some tracers into the breast that are taken up by the lymph nodes, and we can then target those lymph nodes for removal. They go to the lab, they get looked at, and you can extrapolate that if those lymph nodes are clear, the rest of them will be. That if those lymph nodes have got cancer deposits in them, then removing them is good, so you're not leaving cancer in the body. But it also means you might be more likely to recommend aggressive treatment, radiotherapy to a wider area perhaps, and more likely to need chemotherapy. I was just going to say a bit of word about how we find tumours in the breast when they've been diagnosed through breast screen, because most people who go for a screening mammogram don't have any symptoms. There's nothing to feel. And now what we're doing in the picture on the left there, you can see some little titanium markers that are commonly left now in the breast when you've had a biopsy. That means that if you do remove with the biopsy quite a lot of the abnormality, you know where to go back to. And also it means that when you come for your next round of screening, we know which bits have been examined before. They're made of titanium, so they're not magnetic. It allows people to go for MRIs and other medical things they may need. And generally they don't trigger the metal detectors at the airport. When it comes to surgery, though, I and my colleagues need some help to be able to find it. You can't find the titanium ones from the outside, so radiologists help us with that. That picture in the middle shows a couple of what are called hook wires that are going into the area that we want to remove. They would have been placed under local anaesthetic on the morning of surgery. And in the top right of the screen, there's an X-ray of the specimen showing some calcifications on the 2 hook wires that have targeted the area of interest.
So Mike, that's really only for a cancer that you can't feel.
That's literally for the one you can't feel,
Yeah.
yes, and for breast conservation.
Mm.
There are other techniques that are used around the country. There's alternatives to wires. The picture in the middle of the screen there has a little radar detector that we can use a special console to be able to find that within the breast, and other units using magnetic seeds and special magnetic things that are put in either on the day of surgery or sometimes a few days beforehand. So in summary, we've really tried to give you an overview of what we're trying to achieve as surgeons. We talked about surgery for the breast, surgery for the axilla, talked about the reasons why we might recommend one operation over another one. And I've really said that I think to ask your surgeon, what's your thinking? What is the rationale for recommending mastectomy or not recommending mastectomy? If you're having a conversation about the chemotherapy given before surgery, ask questions like, what are the advantages to me of doing that? What are we gaining, or what extra information do we get? And I think another question at the time when you're talking about an operation, say, what other treatments can I expect? And sometimes there'll be a degree of certainty around it, and sometimes there'll be a degree of uncertainty around what to expect, because we need the information from surgery to really make stronger recommendations. Thank you.
Great, thank you very much, Mike. Right, yes, that was very helpful, Mike, and I see there are some questions popping up in the chat box, so don't forget to add yours if you're wanting us to get to that after our next speaker. So I think we all know a bit more about breast cancer surgery than we did at the start of the night, but what we haven't got to yet is the nuts and bolts of getting ready for surgery and the practicalities of recovery. So our last speaker, breast care nurse Katrina Barrick, is going to fill us in on that piece of the puzzle. Katrina, fire away.
Thank you. And thank you to everybody else before. So my name is Katrina. I'm a breast nurse specialist at North Road Hospital. Part of the breast nurse's role is to coordinate care for patients who have been newly diagnosed with breast cancer. Most of that's done behind the scenes. You don't hear about what we're doing, but it's organising scans or following up on appointments. We provide support for patients, a point of contact and a source of information. And I think that's really helpful, because there's nothing worse than being given a diagnosis saying you're going to hear or you're going to get an appointment and not knowing who to call or when to call them. We provide practical support for wound care, manage post-op complications such as seromas, and we also advocate for patients as well and bring their wishes forward to the team. Looking after patients before and after breast cancer surgery, it takes a long time. And time is very limited tonight in what to discuss. And sometimes in clinic, you can spend over an hour with somebody talking through the idiosyncrasies and then follow up phone calls. So excuse me that this is a very, very quick overview. But look, before your breast cancer surgery, so when you come to your clinic appointment, it is important to leave with a full understanding of the surgery that you're about to have. As Mike said, ask as many questions as you need, and also know who you can contact to ask for some more questions on a follow-up basis. I think Barbara spoke about it, and Mike also, take time to make your decision. It may seem like that this is a huge decision to make right now. You've been told you've got cancer. It is an emergency. It's urgent to make your decision on surgery. But actually, it is okay to go home. It's okay to speak to family and friends. It's okay to bring the breast nurse back again, even ask for another appointment in the hospital. This decision is important, and it's important that we get the right one for you. When it's time to plan for your surgery, ask how long you'll expect to stay in hospital after your surgery. If you want your breast tissue returned, talk to your breast care nurse or your surgeon. That's something we can easily organise. And it's also important to remember that no two people are the same, and everyone's care is individualised for them. And I think often we'll have somebody saying, oh, Mary down the road had this and Brenda up the road had that. Everybody's care is individualised for them. So it's okay that your care may be somebody else's. Preparing for your hospital stay. So it will depend on what type of surgery you're having. Exercise as normal, eat well, try and rest well. We have people that will come in and say, look, I've been on a green smoothie diet and I have, eaten just nothing but green veggies for the last week. Don't put your body in a state of stress coming in for your surgery. Keep things as normal as possible. Organise things around the house. So move some frequently used items to lower cupboards or shelves so they're accessible after your surgery. Organise things like transport to and from the hospital and during that initial recovery stage. Speak to work, organise time off work as needed. We can provide letters to support this if that's what's recommended. Organise help with childcare, and especially for the first few weeks after surgery, just to make things easy. A really good tip is to set up a way of communication. Often people do things like setting up a Facebook group or WhatsApp messenger group. This can be really useful as a one point of contact for anybody who needs some information on you, and it saves the arduous task of replying to 40 odd text messages per day. Prepare some extra meals and freeze them. Change your bed linen, change your bed sheets, change your nightwear. Some surgeons would like you to have extra antiseptic washes beforehand. Ask if that's something that's required for you. Packing for your hospital stay. You don't need a lot, because everything you bring in with you, you've got to take home and unpack again. So most people stay in a hospital gown, but just pack some comfortable clothing to wear for when you leave hospital. Most hospitals provide non-slip socks, so you don't even really need slippers. Ask your breast care nurse if you need to have a post-surgical bra after your surgery, what they look like, where to get them, and if you need to pack them with you. Basic toiletries. Take a list of your medications and supplements with you. Ask your nurses as well if you need to stop any of your tablets before your surgery. And most hospitals recommend that you stop supplements at least 2 weeks before your surgery. So again, inquire about that. Take your reading glasses with you if you need them to sign a consent form. Before the surgery, you'll be admitted to the pre-op area and prep for your surgery. Mike spoke about the localization technique. So if your breast cancer is very small and can't be easily felt, then you may need to have a little localization seed or hook wire placed. That localization seed can be placed days or weeks beforehand and will require an extra appointment. The hook wire is generally done on the day of surgery. If you're having a sentinel lymph node biopsy, so that's finding the first draining lymph nodes under your arm, you may need to have another appointment to have a little trace of substance to help, or to inject it before your surgery. And this helps the surgeon find that first draining lymph node during the surgery. Sometimes it's done on the morning of surgery, sometimes it can be done the evening beforehand. And I do believe in certain parts of the country, you may need to go to a separate location to have that done. After your surgery, so you might feel sleepy or drowsy when you wake up from the anaesthetic. You'll be very closely monitored by nurses in recovery. They will check things like your blood pressure, check your surgical wounds. Please let them know if you've got any pain, any nausea, or any other concerns. You may have dressings, or you may just have surgical glue to cover those surgical sites. And depending on your surgery, you might have some oxygen, you might have a drip with some fluids in there. You might also have some surgical drains. Now, surgical drains are used generally for patients who have lots of lymph nodes removed from under their arm, have a mastectomy, or some plastic surgery reconstruction procedures. The drain basically just drains the excess fluid that sits in that post-surgical area. The fluid can be a dark reddish bloody color, it can be a clear color. Either of those is absolutely fine. If you have a drain, you'll go home with the drain, and the district nurses will come to your house to help manage that, and they're really simple to look after. If you've had a blue dye injection during your surgery to help find the lymph node, then your urine, your stools, or even your tears might be a bluish green color for 24 hours after surgery. Most people laugh when you tell them that, but there's nothing worse than going home, getting up to go to the loo in the middle of the night and wondering why it looks like there's toilet duck in the toilet. Going home after your surgery. So depending on the surgery you're having, you may be in hospital for a few hours, few days, or even up to 6-7 days if you're having major reconstructive surgery. After when you leave hospital, you'll be given information on when to expect a follow-up appointment with your surgeon. You'll be given discharge paperwork. You'll also be given a prescription for medications and instructions on how to take those, and those medications being pain relief. If needed, you will also get a medical certificate for work. If you have drains or some special dressings, you will have a referral to the district nursing service, and they will come and see you at home. The ward nurses or your breast care nurse will show you how to care for those drains, how to empty them safely, and how to record the output of those drains. And they will explain the reason and the importance of that to you. If you've had a mastectomy, you'll be given a little soft prosthesis that you can wear when you feel up to wearing it, or if you want to wear it. Often people find that they don't want to wear bras, or they don't want to wear those softies until the drains have come out if you have a drain. Recovery. It depends really on the type of the surgery that you have as to what the recovery will be. Your breasts may look different. They may be swollen. If you've had a mastectomy, your breast will be missing. And to be honest, no matter how much you plan and prepare for that, you can't really anticipate how you will feel. The breast care nurse is often the first person to see you on the ward the day after your surgery. And we will take our time with you. If you don't want to look at the time, we will guide through just checking the wounds ourselves. Some people want a little bit of time by themselves, and that's absolutely fine. From a healing point of view, it can take 2 to 3 weeks for the skin to heal. Stitches take about 6 weeks to dissolve, and most stitches are dissolvable stitches, which is good. You will have some initial bruising and maybe some swelling, and that should resolve over the first few weeks. Please take your painkillers as prescribed or as needed. And I think, Barbara, you spoke about taking the painkillers, and it does make a huge difference because it allows you to rest, it allows you to recover, it allows you to do your exercise as well. You might experience some tingling, some pins and needles, or some numbness, and you might also have a feeling of tightness around the scar as you're healing and recovering. You can shower as normal, but just avoid the direct shower flow onto the wounds. Ask your surgeon or your breast nurse about taping or moisturising the scar a little bit down the track. The do is in bold capital letters. Do your post-op exercises given to you by the hospital physiotherapist. They're boring, they're time consuming, but they do reward you in leaps and bounds, and it's really, really important to do them. And look, try and keep life as normal as possible. It's okay to have friends over for coffee. It's okay even to go out for coffee if you feel up to it. It's okay to get up and make a cup of tea and your breakfast and a sandwich. So do get up and keep moving. At your follow-up appointment, here are some questions that you might want to consider asking. And I think some of these have already been covered anyway. What are the results from my surgery? What are the next steps from here? Will I need a referral to oncology? And what will that look like, and what will that be for? If I do need to be seen by oncology, how soon will that happen? Who do I contact if I've got any questions from here? And look, sometimes we have people that will call us 2 and 3 years down the track if they've got concerns, and that is absolutely fine. If I've had a mastectomy, how do I organise a prosthesis, and how long should I wait before I get one? The breast care nurse will talk to you as well about the Ministry of Health, bra subsidy and breast prosthesis subsidy. If you want to have your breast tissue returned, when can you expect that to be returned from the surgery, and what's the process for doing that? And really importantly, what will my plan for surveillance be? How often will it be, and what will that entail? And then Breast Cancer Foundation, and I know Barbara, you said about speaking to Louise on the phone. With Breast Cancer Foundation have got some specialist breast nurses advice. That advice line is Monday to Friday. They've got support aids that they can send you out free of charge, and they really are useful. There's a MyBC, which is an online patient community for support. And then obviously there's the webinars and the information on the Breast Cancer Foundation website. I think, look, to cover it all, it's very easy to talk about the physical preparation from the surgery and the physical recovery from the surgery. What can't be covered tonight is the emotional toll that it can take on you and on your family. And the fact that it's a process to work through. Being told that you've got a breast cancer is very, very scary. Even if it's something that is totally curative, it is very scary. So take time, look after yourself, get support, and keep accessing that support. And look, talk to your breast care nurse about what supports are available, both from the Breast Cancer Foundation, internal within the hospital, and support for family as well. Thank you.
Great, thank you. There's so much information that was super helpful there, Trina. Thank you. We're now going to open up to questions from you at home. Keep typing your questions, and we'll get through as many as we can before the time available, before the time's up. The first question is actually for Amy, which is, Amy, how long was it before you were able to use your upper body sort of normally and so on?
How long before I could use my upper body? It depends what I guess it depends what you mean, what was using my upper body for. Obviously movement was very limited for the first probably 2 weeks while I still had my drains in, so I wasn't really doing an awful lot of movement with my upper body, but I was really encouraged by the nurse to move as much as I could and to do the exercises. I'm trying to remember how long it took. I would say it was a good few weeks before I was kind of, to go driving and things like that was a good few weeks as well. And lifting, you just have to be super careful because you know, and obviously everybody would be different, but I think it was like a good few weeks before I could really start moving it properly.
I think the physios often say to wait a good 6 weeks before you start adding any weight at all into your exercises. And even at that, it can be started with a can of baked beans to do some of your exercises, but waiting 6 weeks before you put any weight through that upper body at all.
Does it actually baked beans?
It could be absolutely anything. And a dog food if you want.
Great. We have a few questions around timing, so Mike, probably some of those, most of those are going to go to you. How soon should you have your surgery after your diagnosis, assuming you're not having neoadjuvant chemotherapy? How long should how soon should you? We've talked about take your time.
I think ideally within a few weeks. There are some factors. We talked about grade. So the grade is something that comes on the pathology report about how fast something might be growing. The reality is that breast cancer start with one cell that divides to two, and then but that actually happens and then to more, and perhaps for some people it comes up at screening or it comes up as a lump that they can feel. It's actually been growing for weeks or months. In the public system, we have Ministry of Health targets of trying to get operations done within a month. And I think that is a safe thing. Things are not going to advance, progress, get out of control in that sort of time frame. Katrina talked about the mental side of it. Psychologically, you want it done as soon as possible. We want it done yesterday.
Right.
That's the reality of it, though. But equally, I think what I'm saying though is that you don't have to have it done tomorrow from a prognosis point of view, and it is definitely worth taking the time to make sure you're making a surgical decision that you're happy with, and that you're going to be happy with in 20, 30 years' time.
One of the questions around time we've had here is from a lady who's 60 years old with a lobular breast cancer with some nodal involved, her lymph nodes involved, and sounds like she's been waiting nearly 3 months. Does that sound like something you should be to follow up from the doctors to see what's happening?
Yes, I mean, I don't know if some of that delay has been around further tests being done, but I think that would be a great example to ring the breast care nurse and say, is there a plan? Is there a date? And I think sometimes, the big public hospitals can be really frustrating sometimes with the bureaucracy and administration, and that's one of the key roles that breast cancer nurses have. It's a point of contact, and a friendly one at that. And you'd be amazed how much red tape they can cut through, hot knife through butter in the background that you never see. They do a huge amount of work, and you didn't major on it, Katrina. The word advocacy was there for that, so I'd be getting onto your breast care nurse and saying what's going on.
Excellent. And Katrina, is that the kind of thing you end up?
Yes, absolutely, absolutely. Trying to expedite scans and appointments, and just making sure that we actually do follow the Ministry of Health guidelines with the faster cancer pathways, and we work to that.
Okay, and of course sometimes things do get overlooked, so definitely a good idea to talk to someone about that. Also on timing, how long should it take to get your pathology results back after surgery? How long do you generally need to wait for that?
I think that would be quite variable up and down the country, depending on what the laboratory can come with. I think across the Auckland laboratories, it's about a fortnight.
Great. If you have a double mastectomy, how long before you can have reconstruction? So guess I'm not sure if that means waiting for the whole surgery or if it means after.
If you need to have radiotherapy, that can sort of be a little bit of a caveat in there. And the recommendations that you wait at least 12 months after completion of radiotherapy before you'd even have a discussion on breast reconstruction. And that's just to allow time for the breast tissue or the chest wall tissue to heal well.
Right. Is the wait for a mastectomy due to patient choice longer than the wait for a mastectomy? I guess that's more urgent, more regular, where there wasn't so much of a choice element involved.
Generally, no. What can sometimes add to waiting times if people are choosing to have a reconstruction, because I mean, we've talked about the decisions and the discussions you might have between breast conservation and a mastectomy. With reconstructions, there are more discussions to have, more decisions to make, and sometimes it's involving with a plastic surgeon as well, so that may need further consultations and appointments. So it can take longer logistically to organise a mastectomy with a reconstruction, but a simple mastectomy shouldn't be any longer.
We talked about like the possibility of sometimes if you have your chemo before your surgery and it shrinks everything down, it might end up changing what kind of surgery you have. How often would you say that happens? Does it actually lead to a different kind of surgery?
So for that to be even an option, it would have to be just one deposit of cancer in the breast. So if someone has got a multifocal cancer across several areas of the breast, we know at the outset before even starting treatment that we're going to recommend a mastectomy. So hopefully that's something we do say to people. That's something to ask. If it is one deposit and then treated with chemotherapy up front, maybe up to half of them may get tumour shrinkage that would change the type of surgery.
Right. Now a question about cosmesis, what we call cosmesis, the look of the breast after surgery. Someone who says, I'm 6 weeks after a lumpectomy and sentinel node biopsy, have hardening around the tumour site. Nipple is not symmetrical with the other breast and I have a divot. Is this still too early to be disappointed in the cosmetic outcome?
I think 6 weeks is quite early. I'd imagine there may be radiotherapy as well. So what it's going to look like is still a work in progress. Two things to that component. One is the look and the other how it feels. It is inevitable that the breast where you've had an operation will feel different. It won't feel forever as it does now. And over even 12, 24 months, that tissue is going to soften. So that's the feel. But what we're trying to do is get as close to possible as a breast-shaped breast, not a breast with a divot.
Right.
Yeah, but in terms of any corrective actions, it's probably a case of letting things settle down, let it heal, have the radiotherapy, and then probably again leave it about 12 months before you start operating on or trying to touch anything that's had radiotherapy.
Barbara, how did you feel about the look of your breast and how long did what was the sort of timing?
Yeah, it took a while before it sort of settled down after surgery. I was, taking off the bandages, I was quite anxious, but it was quite swollen at that point, so I couldn't really tell. I think once it had settled down, it was a bit different shape because quite a lot of mass was taken out from underneath. So the nipple was sort of pointing in a different direction than they were both quite symmetrical before. Yeah, now nipple points down a bit. And it's a bit sort of flat underneath. And then with the radiation, it's got a bit larger. So in fact, the breast that had the most removed is now larger than the other one. But I'm told that as the effects of the radiation wear off over time, that might reduce. But I'm fine with the shape of them, really.
Quite hard to predict what.
I'm not actually all that bothered about how I look. I'm more concerned about functionality and how I feel. So
right.
But if you are concerned about how you look, those things are a much bigger issue. Yeah.
Just another question around symmetry. Mike, does the public hospital consider cases for plastic referral where the non-cancerous breast looks very asymmetrical? I guess.
They'd certainly consider it. I think different units have different pressures on them for what they'll do in terms of bilateral surgery and symmetry.
They're different units, I mean different regions.
Yes, different regions, yes.
Right. Okay, let me see what else we've got here. Been told my lobular cancer won't need chemo, will instead have letrozole radiation and surgery. Is it possible this could change when the pathology of the breast and lymph nodes is tested?
Correct. That's what I'm saying. Given the information available now, that's the most likely scenario, but it can be subject to change.
And I think that in the last webinar that we had, Sheridan Wilson spoke really well about lobular breast cancer and chemotherapy. So it may be worth that person going back and going back and looking at the criteria for chemotherapy for lobular breast cancer.
Just a few weeks ago, we did have a webinar on lobular breast cancer, so do watch that on our website. Let's see. Is testing for HER2 standard, or do you have to ask for it?
Standard.
Okay. And got bottom here. Can implants be placed post radiation? I've had chemo, lumpectomy, and radiation in 2022. Since then, learned to have BRCA2 variant, so looking for double mastectomy for risk reduction.
So this is, you've had breast conservation and radiotherapy, is that what you're saying?
Yes.
Yes, we tend to, breast tissue that has had radiotherapy to it is a bit more, you have to be a bit gentler with it. Sometimes if a plastic surgeon or an oncoplastic surgeon is doing an implant under the muscle can be less stretchy, so you may not be able to get to the same size. So it comes with caveats, but it is possible.
How do you protect weak skin from radiotherapy?
The radiation oncology nurses at the centre that that person is going to have got some really good tips and advice. There are some amazing skincare products out there. There are also ones that you really cannot use. So chat to them and they will tell you the do's and the don'ts, and often they'll provide the creams and lotions for you. If the skin from if you have a breast conserving surgery and you're having radiotherapy and you're finding that your skin is quite sensitive around it, a good tip is to wear your bra inside out.
Okay.
Because you've got all of the seams on the inside, which will be aggravating. The only person that knows it's inside out is you.
And that bust
I wore
right
t-shirts.
across.
I wore t-shirts inside out too for that reason.
Yeah.
Yeah, it seems not.
Yeah.
Yeah.
Okay, that's good tip. Thank you. Let me see what else we got here. Just about finished, I think. So, how soon can lymphedema develop after surgery? We had a little chat about this earlier.
Good.
It can develop a couple of months after surgery. Some people say within a couple of weeks, even if there's lots of nodes removed, but it's very hard then sometimes to tell whether that's just in post-surgical swelling or whether it's lymphedema itself. Sometimes it can develop a couple of years, or even the odd person, it can be 15, 20 years after surgery that they can develop an lymphedema. Yeah, it can be very random.
And what's usually the first symptom?
Often a feeling of weight or heaviness in the arm. Might notice that a ring is too tight or a watch is too tight. What did you notice, Amy?
Swelling in my arm and heaviness. I just really felt like, even though after the surgery I was very numb, my arm just suddenly felt really heavy, and I could notice that my clothes were getting tighter. So yeah, that was the first sign for me. Was the swelling. Yeah, and it was like my lymphedema developed about, I think, 3 months after my surgery. So yeah.
And often at the very start, it's hard to differentiate because
Yeah.
your arm already feels
Yes.
fatter and feels
Yeah.
more swollen from that numbness
Yeah,
in there, so it's hard to know
absolutely.
what's
Yeah.
what. And
Yeah, so mine got quite swollen. I got quite swollen before I really knew what it was.
And should people be expecting to be checked for lymphedema or?
that would be lovely.
Yes.
No. But for most people, they should be educated on what lymphedema is, and often that's the role of the breast care nurse to do that post-surgery. Tell you what the signs are, what to look out for, how best to try and avoid it or manage it. And then I guess if there are any symptoms that come aboard, whether it's in the early stages, speak to the breast care nurse or breast surgeon, or if it's down the track, just chat to your GP and they can do a referral. Most hospitals have got a lymphedema service of some sort.
Right. And one last question, this one for Mike. How many lumpectomies would you have to get margin clearance before deciding you should have a mastectomy?
Personal choice again, depends on how patient to patient. I think a standard would be, if you're coming for your third operation should probably be a mastectomy.
Great. Okay, right, our time is up. So thank you very much for joining us tonight. And thanks again to Amy, Barbara, Mike and Katrina, and also to our producer, Hannah. You've all been absolutely fantastic. We hope that you at home found this helpful. Tomorrow we'll send you a link to watch again online, or to send on to friends to watch. We'll also include a link to an extremely short survey that we'd really appreciate you filling in less than a minute to just tell us what you thought of tonight's webinar. If you have any questions about breast surgery or any other aspect of your breast health, breast cancer, our nurses are available to take your call, as Katrina mentioned, on our 0800 BC nurse line during office hours. I think we have a slide coming up. Yep, you can see that number there, and also information about our online community, MyBC, where you can talk to other people who are on the same journey as you. Thank you again for joining us. Ka kite, good night.